at the University of Cape Town. Welcome once more to our UCT-African Wednesday meetings. Today, apologies, I have a bit of a post-nasal drip, but I will try and lead this discussion of a case that I saw in the outpatient sometime last month, which was a glomus, which was a case of a glomus tumor. So this is basically the outline of my talk for today. I will start with a brief case discussion, and I would look at a bit of literature and try to give you an approach to glomus tumors and try and summarize everything at the end. So I obtained consent from the patient for use of the radiological images and the clinical information, and to be shared, and for that to be shared on this platform. And I've quoted my reference as I go through my presentation, and there's no intention of any copyright infringement. So without further ado, I'll go on to the case presentation. This was a 41-year-old female patient who came to our OPD with 9-year history of right-sided pulsatile tinnitus that was, asynchronous with the pulse. She had associated subjective hearing loss with the sensation of oral fullness on the right side, no concern on the left side. And of note, she really did not seek any medical attention for the past 8 or so years, and actually her first presentation was at George Hospital about it was last year. So some of the important negatives from the history: there was no history of any otalgia, no blood urturia, no history of any vertigo, no dizziness, no facial weakness. There was no family history of any tinnitus or any family suggestive of paraganglioma history. There was no autophony, and essentially no systemic symptoms, no palpitations, or anything suggestive of a secretory tumor. On background history, she was asthmatic and was also concurrently diagnosed of COPD, poorly controlled, and was on kind of daily short-acting and also long-acting bronchodilators. And she was also diabetic. But however, the diabetes was well controlled on oral hypoglycemics. She was hypertensive controlled, and she was also a social drinker. So on examination, on the e-examination, I'll go into the general examination data. She had this red pulsating mass behind the tympanic membrane, as you can see on the video. So this was just an endoscopic view to demonstrate this the pulsations. And on pneumatic otoscopy, there was blanching of this lesion, and the left ear was normal. And on general examination, she had high BMI. Rest of cranial nerves were preserved, especially the lower cranial nerves 9, 10, 11. She had baseline audible wheezing from the poorly controlled asthma and COPD. Flexible nasal endoscopy was essentially normal, with normal cord movement, no signs of any kind of lower cranial nerve neuropathies. And on neck examination, there were no pulsations. Even on neck compression, there was no resolution or disappearance of the pulsatile tinnitus with compression of the ipsilateral carotid and IgG. And then unfortunately, I don't have the picture of the audiogram, but here on the audiogram, I had complete conductive loss on the right side with normal hearing on the left ear. At this time, I want to open it to the floor. I think the diagnosis is probably obvious. Maybe if someone wants to comment on the most likely diagnosis and the differentials. Maybe I can pick Tafat Yamroa. You can maybe comment on your thoughts.
Hello, everyone. Thank you for the presentation, Charles. I think from the history, I would most likely be thinking of the etiology. It's from the history and also the scientific findings. Thank you.
Do you want to comment on the differentials? Okay, maybe I can just go on. So basically, these are some of, I think the diagnosis is obvious, quite more obvious from the history, but excuse me, Divya, do you mind just muting, I think all participants? There is quite a lot of background noise. Hello, Divya. Okay, maybe I can just try and go on. Maybe if the participants don't mind muting their microphones, it's quite difficult to go on with the presentation with quite significant background noise. But these are some of the differentials that one can consider in a case of pulsatile tinnitus. You can basically divide them into vascular pathology that could either be arterial or venous, or microvascular pathology as listed, be it glomus tumor or Parker's disease, cavernous hemangiomas or meningiomas of the middle ear. You also have to consider some circulatory issues like high output conditions like anemia, thyrotoxicosis, and pregnancy. That's why it is important that if in a young patient who presents with pulsatile tinnitus, you always have to exclude pregnancy as the cause, and well as other considerations like benign intracranial hypertensions in the typical phenotype, that is like in high BMI patients presenting with signs of CSF leak. And also in patients with superior semicircular canal dehiscence, they may present with pulsatile tinnitus in addition to the other signs and symptoms. Importantly, I think one of the most common questions is like the differentials of a red mass behind the tympanic membrane. I think the most kind of common things that you can think of in addition to glomus tumors would be like hemotympanum in the setting of trauma. You can also think of like a high writing jugular bulb or dehiscent jugular bulb or jugular bulb diverticulum or apparent internal carotid artery. Those are kind of the common things that, if you see a red mass behind the TM, those are the things that you need to think of. So when the patient presented, she already had imaging from the base hospital. So I just, shared just a single slices on each plane. So on the coronal image, I think we can appreciate that on the right side, there is kind of this soft tissue density that is centered around the promontory area with opacification of the attic. We can appreciate a bit of a part of an ossicle. Very importantly, there is no like medialization of the ossicles, and the sputum is also not blinded. And you can appreciate that there is kind of no continuity with this lesion with the jugular bulb, which is quite important if you're trying to differentiate a glomus tympanicum from a glomus jugulare. I know at times it can be quite difficult to differentiate the two, whether if the lesion arose from the tympanic side or from the jugular side, if there is erosion. This is actually important if you are to employ preoperative embolization in these cases, because if it's a glomus jugulare, one may it's commonly most commonly the fitting artery will be the ascending pharyngeal artery, and one may want to embolize preoperatively. And then on the axial view, you can also appreciate this soft tissue density that is in the middle ear. Is also extending partly to the bony part of the station tube. Yeah, basically that's all we can appreciate from this message, from this image. And then fortunate enough, this patient is subsequently obtained an MRI scan quite quickly. And on the MRI scan, to my left, or to our left, this is basically a T1 weighted axial view. This is a contrasted image. You can see the tapinets are quite lighting up, which basically shows that there is this contrast enhancing lesion that's centered around that middle ear area. It's actually vividly contrast enhancing, and there's what looks like fluid in the mastoid cavity on the right side. And then on to our right is a T2 weighted coronal image, which basically shows this lesion that's centered around the middle ear with which is hyper intense to brain matter. And I mean, it's difficult to appreciate any the salt and pepper appearance due to the signal voids. In this case, I think this is due to the fact that this has a fairly small lesion. And of note, also in this case, there was no intracranial or onijural involvement. So in view of these patients' multiple comorbidities and poor kind of surgical candidacy, we referred this patient for discussion in the neuro-oncology clinic for further management. And then this brings us to our topic of presentation for today, which is glomus tumors. I will pay a particular attention, or I will probably focus more on the jugular or tympanic paragangliomas. So glomus tumors are essentially neuroendocrine tumors that arise from an extrarenal autonomic paraganglia. They are quite rare, and but most commonly, they are the most common vascular skull-based tumors of the temporal bone. In about 80 to 90% of cases, they are sporadic, and they and in the remaining cases, they are familiar. They are basically very slow-growing tumors and locally destructive. And in most cases, about 97% of cases, they're really benign. and locally aggressive. In the remaining cases, they've got malignant potential. So as I have alluded previously, about 90% of cases are sporadic, with about 10% of cases being familial, and they are inherited in an autosomal dominant manner with a mutation in the mitochondrial succinyl dehydrogenase gene. And the familial cases, they tend to present earlier, and they tend to be multifocal and more aggressive, and they tend to be more secretory. And in about 10% of cases, they present as multiple tumors, and 10% of cases they present in the pediatric population. So if we look at the classification of the head and neck glomus tumors, by far the most common tumor site is the carotid body tumors, which account for about 70% of cases in the head and neck. These essentially arise from the carotid body and typically do not involve the temporal bone. And the second most common tumor types is the glomus jugulare, which is actually the most common type is in the temporal bone and arising from the jugular bulb, followed by glomus tympanicum, which essentially arises from the Jacobson nerve at the promontory area. And these glomus tympanicum, as compared to the glomus jugulare and the other tumors, they tend to present a bit earlier, between 40 to 50 years of age. And lastly, you can have the glomus vacali that arises from the paraganglia around the vagus nerve at the skull base. And if we look at the clinical presentation, these the patients with glomus tumors are often asymptomatic because these tumors are very slow growing. You find that at presentation, probably the tumors have been there for quite a significant amount of time. But in about, in excess of more than 50% of cases, they will present with the pulsatile tinnitus, associated conductive hearing loss. They may present with multiple cranial neuropathies, cranial nerve from cranial nerve 4 to 12. They may also present with oral fullness, dizziness, blood otorrhea, facial weakness if there is any compression of the facial nerve. And also these patients may also present with kind of classic syndromic, classic pictures of these syndromes. They can either present with the classic jugular foramen syndrome, or what we term as Vennet syndrome, that is, involvement of the cranial nerves that pass through the jugular foramen, that is cranial nerve 9 to 11. Or they may present with Villarret syndrome, which is basically neuropathies of cranial nerve 9 to 12 with Horner's syndrome, or involvement of the sympathetic chain. And with Collet-Sicard syndrome, they present with basically cranial nerve neuropathies of cranial nerve 9 to 12 neuropathies. If we look at the signs of glomus tumors, if you are examining your patient, one may notice the rising sun appearance, which is commonly seen in glomus jugulare tumors as they arise from the hypotympanum. One may see a reddish pulsatile or reddish blue pulsatile mass that is medial to the tympanic membrane. And you have to do pneumatic otoscopy, and you will actually notice blanging with positive pressure. One can elicit equinus sign, that is, apologies about the spelling error there. One can actually notice, if you compress the ipsilateral carotid, there should be decreased pulsation of of the mass. And this patient may also present with hemorrhagic polyp in the external auditory canal. I've seen one patient that presented with a polyp that was actually, extruding through the external auditory canal that we took to theater for a biopsy, which actually confirmed that it was actually a glomus tumor. And if you auscultate the patient, one may actually elicit the bruit over the mastoid or infraauricular area. And then because these are vascular tumors, they've, there's a high risk of bleeding. So you find that in most cases, biopsy is contraindicated unless if we're not sure of the diagnosis. But fortunately enough, most of these, scalp-based lesions, they've got characteristic imaging features which enables one to actually diagnose them on imaging. So some of the features on some of the features on a CT scan, these tumors, as we know that they are quite vascular, so they vividly enhance with contrast on the CT and on MRI scan, and they've got this characteristic bony destruction or a moth-eaten appearance, as you can appreciate on this image. And typically of jacular glomus tumors, there is that erosion of that carotid jacular spine or bony interface, and then there may be involvement of the middle ear or mastoid as well. And then on MRI scan, the reasons why one can obtain the MRI scan is, one, to confirm the diagnosis, and if to assess if there is any intracranial extension, be it intra or extradural, and to detect any concurrent paragangliomas. As you can find that, in cases that one has got classic, clinical presentation with a small kind of glomus tympanicum that's isolated, that's isolated to the middle ear, one may not need to obtain an MRI scan if you are to embark on surgery. But features of the glomus tumors on MRI scan, they are hyperintense to the brain on T1, and on T1 with the contrast, they vividly enhance, as you can see in this image. And on T2 imaging, they've got this characteristic salt and pepper appearance, and the salt appearance is due to the subacute hemorrhages within the tumor, and the pepper appearance is because of the high flow signal voids of the feeding arteries. And then some of the investigations that one can do is, like, for example, 24-hour urine catecholamine screen for a VMA, and in cases of if you're suspecting secretory tumors, or if a patient has got multiple paragangliomas, one may want to screen for any presence of secretory tumors. And one may employ angiography, especially in cases of large tumors, where one may want to employ preoperative embolization. And there is a role for radionuclide scanning with the indium. These tumors, they contain they contain somatostatin receptors. So one can actually, the indium 11 octreotide scan is quite sensitive. It has got more than 90% specificity and sensitivity for paragangliomas, because they do uptake octreotide due to the presence of the somatostatin receptors. And the other kind of radionucleotide scans, like the 1, 2, 3 iodine meta-iodobase guanidine scan, it has actually comparable sensitivities to the indium octreotide scan, and can also can also be used as a diagnostic tool. And then a PET scanning is actually useful if one is suspecting malignant transformation of the glomus tumor. And then if we look at staging, I think by far these are the two most commonly used staging systems, the FISH and the Glasgow-Jackson staging system. I won't go into much detail about this, but basically this helps you in terms of planning whether, especially with the FISH staging, it helps you in planning your surgical approaches. You find that FISH type A is basically tumors that are limited to the middle ear, that are amenable to surgical resection, as well as FISH type B tumors. And as we go to FISH type C and D, you may need to be more aggressive with your surgical approaches. I will discuss that later. And if we look at the management of glomus tumors, in addition to the institutional factors, one should always, like institutional factors, surgical factors, one should always consider the patient's age, the size of the tumor, its rate of growth, genetic makeup, as well as the presenting symptoms. If the patient has got signs of either brainstem compression or multiple cranial neuropathies, and you also need to take into consideration the patient expectation, taking into account the mode of treatment that one might employ. But basically, these are the management options. As we know, the natural history of glomus tumors is that they are very slow growing tumors, and their growth rate is about less than 1 millimeter per year. So there is actually room for watchful waiting in selected cases. So you find that due to the natural history of the glomus tumors, it's actually difficult to assess the success of non-surgical therapies, because one may not know whether it is, there is actually reduction in growth, or it's just a sequence of the natural history of the tumors. And then if you want to employ surgery, one has to weigh risk versus the benefit, because surgery also comes with its risk, especially for large tumors, and with risk of nerve damage, hearing loss, strokes, and blood pressures in case of secretory tumors. And there is an option of radiation therapy, which actually has got a fairly good control. And some studies have spoken about somatostatin analogs, which is still kind of and still under which is still under kind of reviews. And one may also, it is important that when you manage this patient, you also have to address hypertension or hypertension associated with either these secretory tumors, or if you are going to excise a secretory tumors, one may develop orthostatic hypotension. And then especially with large tumors, preoperative embolization can also be employed. It is actually useful adjunct if in case of large tumors, as it will cause a tumor shrinkage and reduce your intraoperative blood loss. However, this should be done within 48 hours to prevent recruitment of collateral circulation. And if we look at radiotherapy as a treatment option, it is, due to the complications associated with radiotherapy that we know, it is not a modality of choice for surgical resectable tumors, especially in young and healthy patients. However, it is indicated in patients who are poor surgical candidates in cases of recurrences and in unresectable lesions. And in systematic reviews, they've actually shown that one can achieve about 95% tumor control and about 47% symptomatic control with stereotactic radiosurgery. And in literature also, there are comparable outcomes with the stereotactic radiosurgery with the surgery for tumors that are less than 2.5 centimeters. And then if we look at the surgical approaches, fish class A tumors, these are tumors that are limited to the middle ear, especially in a young, healthy patient. You know, one may opt to completely excise the tumor to achieve cure. So these can be approached whether transcanal, you can even employ end oral or post-auricular approach, and one can also use bipolar to shrink the tumor. And then if we look at the fish class B tumors, these are tumors that are involving the mastoid or, you know, the hypotympanum as well. So these are tumors that are amenable to either end oral or, you know, a post-auricular approach. You know, in these cases, you may want to do an extended facial recess approach and sacrifice the chorda and the vaginal process of the temporal bone in order to access that hypotympanum. And last but not least, for large tumors, that is fish class C and D, traditionally, you know, these fish infratemporal fossa approaches were basically kind of defined for these lesions. So in this diagram, basically, it shows the access that one gets with the fish type A. This is actually employed for the fish class C and D kind of jacular paragangliomas, and this gives you access up to around the station tube area, and the fish type B gives you access up to foramen ovale, with type C giving you access up to the foramen rotundum. So you see that, you know, as your tumors become more aggressive and there's involvement of the kind of anterior petrous apex, one may need to employ the type B, fish type B infratemporal fossa approach, and then tumors that go as far as the paracellar area and kind of clivus area, you may need to be more aggressive and employ the fish type C approach. I'm not going to go into much kind of surgical detail in the interest of time, but that was my last slide of my presentation. So in summary, so glomus tumors are quite rare and they're very slow growing tumors, and they tend to be locally aggressive, but however may lead to significant morbidity, and we should employ a multidisciplinary team approach and address patients' expectations when we manage these cases. And of note is stereotactic radiosurgery is comparable outcomes to surgery, and it's becoming the preferred modality of treatment for selected small tumors. And however, surgery remains the mainstay of treatment in young, healthy patients that are amenable to complete excision. Thank you.
Thank you, Charles, for your presentation. I just want to see if there's a comment. Any questions from the gallery? I just want to say unmute.
Yeah, Charles, thanks for the presentation. It's very difficult to differentiate between Glomus tympanicum and a type class A and a class B tumor. And sometimes even just a little bit of erosion in that hypotympanum, you rather stage it up rather than stage it down. And the significance of that is, if you've got a class B tumor, tumor of the hypotympanum, it's a little bit more difficult to surgically resect the entire thing. And there's been a large movement in these in terms of management and they're largely going conservative, even in the very large tumors, even in the healthy young patient. And the reason is the mobility attached to surgery. So you'll find places like the Netherlands, even in huge tumors, they don't operate on these, they manage these conservatively. These are very slow growing, like slow growing than the vestibular schwannomas. And the worst thing is to take a young, healthy patient and then to operate on them, and then post-operative, they get cranial nerve palsy. It's quite devastating to do that. So I think even those centers that are doing them, they really cannot say that the incidence of cranial nerve fallout is low. I mean, I know now you're not going to get the same figures as for stereotactic radiosurgery, and they've got a very well known sort of, they stop the growth. And the incidence of cranial nerve fallout is a lot less, significantly less than surgical options. And the problem is, I think, that not that many centers have, particularly in developing countries, they don't often have stereotactic radiotherapy available. I think that's the problem. And these are tumors we don't want to irradiate because they can still grow with radiation, but stereotactic is very effective. As you said, in about 95% of patients in terms of stopping the growth. I think it's the availability of that stereotactic radiation. I've not seen, I think this is the first one that I've seen in a very long time. I used to see, they're not common, but still used to be referred a lot more of these before, and I'm not seeing them as much, and I'm not sure if they're just not being referred, or if the incidence has gone down. But yeah, we're very conservative with these. The tumors that we would investigate in terms of whether or not they neurosecretory, the tympanic ones we don't usually, but anything from class B up to Glomus strobulari, those ones we do routinely investigate for with urinary leaves. But the patients who are asymptomatic, well, for that matter, even if they're not asymptomatic, there's still a large tendency towards conservative treatment. So we refer them to the neuro-oncology of this institution. They obviously assess them, they do the MRI, and look at the rate of growth, then they decide on NDT or whether or not they proceed. So even if you have a Glomus tumor, you don't not necessarily going to proceed to stereotactic radiotherapy. It's very much going to be determined based on your symptoms. The one thing about the small ones with conductive loss, if you have a Glomus of the tympanic Glomus tympanum, and the patient's got a lot of conductive loss, I think the one issue is those ones, they're tricky. You can surgically offer them, you can offer them surgery as an option. Offering them a stereotactic radiosurgery, the problem with that is they can't spare the cochlea. So they may potentially taking someone from conductive loss with the risk of a sensorineural hearing loss. So those patients are the only ones that I think are actually going to operate on, because you want to reverse the conductive element of the hearing loss. And they can't get that same effect with the stereotactic radiotherapy. But even those ones, this patient in particular, it was the comorbidities really that I said no. I know that she's got a big conductive loss, but she had far too many comorbidities. And then the other thing just to remember is if they are metabolically active, even if they undergo stereotactic radiosurgery, they still have to be blocked with what do you call it now? Alpha blockers. They still have to be blocked with alpha blockers, even if they get in stereotactic, and that's why you have to check those levels. It's not just for the surgical case, it's also for the stereotactic.
Thanks, Hashim. I wanted to, so maybe for I know we see these quite rarely, but they are quite a common exam topic. So in kind of for exam purposes, I know if, for example, if you've got a fish or like a small glomus tympanicum that's isolated to the kind of promontory, in that case, like without a conductive hearing loss, in that case, would it be reasonable to say you would, I mean, first line, you would manage this patient conservatively and repeat imaging in like 6 months to a year, though it will be like, if the patient is young and healthy, would you still kind of employ the conservative approach as first line, or in that instance, you would offer this patient surgery since you've got a chance of cure?
I think for exam purposes, yes, you would still manage conservatively. You must remember it's not what you can do to a patient, because we can operate on these patients. The problem is that we know the evidence out there is that the morbidity rate is that much higher. And the evidence is that they do better with stereotactic. It's conservative, and then if you do something, ideally stereotactic first. So just because a surgeon can do something doesn't mean it should be done. It's, it's got to be evidence-based on what is in the best interest of the patient. And I think if there are some surgeons in South Africa who are operating on them, they need to go and read the literature and really ask whether they can, can you really justify operating on them? Just because you can doesn't mean that you should be. You have to give patients every single option. I mean, that's not informed consent. Informed consent is about telling the patient about every single option that is available. And I can tell you now what patients choose if you really spoke to them about. So I think an examiner who's expecting you to say surgery shouldn't be an examiner. Because that's not, they're certainly not the ones I would be expecting to examine candidates.
Okay. No.
Actually, I just wanted to ask for current disease for radiotherapy. If it is resectable, would you resect and then offer them radiotherapy, or would you just resect and watch?
I think because it's very large, when they start going into training, the neurosurgeons have to develop those where they can, and then offer them a post-operative stereotype. No, there's nothing wrong with that. And that the whole purpose of that is to try and preserve the lower cranial nerves if you can. Yeah.
But if you can get it out in completion with recurrence, did you then
it's very rare. If you can, then obviously, but it's very rare. I think they manage to completely resect it, yeah, without getting any residual tumor behind it. Because these tumors are quite infiltrative. Yeah.
There's many with what Tasneem said. We have become far more conservative with our benign things in the schwannomas as well. The facial schwannomas we used to operate on, but if I think you're condemning a patient to immediate facial weakness, which might take years to come on.
Yeah.
The same thing with the glomus vagale tumors, that we think spot therapy, because otherwise you end up with the problem.
Yeah.
The patient is forced lateralized cord aspiration. And the growth body tumors, a significant number of them end up with a hypoglossal nerve palsy. And so I think one has to have a conversation. And I think what strange things is our imaging. We can now trace patients beautifully.
Yeah.
30 years ago, our imaging wasn't really good, and now you can track the growth of the tumor by millimeters. So, I think that probably changed things, and the fact that we can actually make a diagnosis on that.
Yeah. I mean, I once spoke to a surgeon who he operates quite a few of these, what he's used to. And he said the worst experience he's ever had is taking a young man and with a Glomus trabecular operated on him. And then he aspirated months later, and he was getting married and went on honeymoon aspirating. And so, I mean, that's not, it's destructive surgery. And I think the people that are at congresses that are saying, oh, they get an 80%, success rate with no cranial nerve palsies, I think they should go and have a look at their figures. I mean, I question those. I just wonder, because it's very difficult when you're actually operating to dissect the nerves free of that tumor. Once you get onto the plasma war, you can't separate those things. It's so inherent. Even the best surgeon in the world can't set it free. So I think they should really go and, and then there's the argument, well, if they've got the cranial nerve fallout, just go and operate on it. Well, it's still surgery with the risk of carotid blowouts, etc. And you have an option of stereotactic radiosurgery that stops the growth very effectively in over 95% of cases. The cranial nerve palsies are not going to change, and so I can't see why you'd want to go any other route. Yeah.
Thank you, Tashneem. Is there any more questions from the audience? Charles, do you want to say any final comments?
No comments, but yeah, I don't see any other questions from the chat function either.
Yeah.
But yeah, thanks very much for everyone for joining and for all the contributions.
We would just also congratulate Charles for passing his college exams.
Well done, Charles. Thank you, everybody.
Thank you, bro.
All right, thank you, everybody. Have a good day.